Start here. You're all very welcome to today's meeting, and just to declare the meeting is now open to the public. And just to note as well that the committee meeting will be recorded and is being broadcast online as well. If I could just advise members and anyone in the public gallery that you're welcome to use mobile devices as long as they're in airplane mode and muted, but it's not permitted to take photographs or to record any of the meeting. Just in terms of apologies, I think we've one apology from Linda Dillon. Are members aware of any other apologies at this stage?
Alan's on his way.
Alan Robinson's coming. Okay. Thank you, Diane.
We were at a meeting.
No problem. Item number 2 then is under Chairperson's business. So I suppose just to note today, our meeting here is at the NICON conference, and we're delighted to be here. So just to pass on our thanks to NICON 2024 organisers and to the Le Mans Hotel for hosting the committee today. I think it's the first time we've done something like this, so we're really excited to be here, and it's been a great couple of days meeting with lots of people from right across the health and social care sector. The conference has definitely provided the committee with an exceptional opportunity to engage with the sector, and we've been very impressed with the wide range of discussions that have taken place. Members will know that yesterday we had our own session of Meet the Committee, and thanks again to everybody who participated in the session. I think it was extremely valuable, and we had some really important and useful discussions, so there's lots for us to take away as committee members and to inform our work going forward. And I also hope that those who were in attendance find it very useful and learned a lot about the work of the committee. If I could just remind members as well that a number of us attended the department's Bengoa conference last week here in Le Mans on health and social care reform, accelerating change, and I think others would agree that was also a really, really good conference, and the discussions and with the chair, Professor Bengoa, and the members of the expert panel who produced the original report in 2016 was really, really informative, and I think it's certainly rejuvenated the whole discussion around transformation of our health service. And I think it has really, the key takeaway for me, and I would imagine others would agree, is that acceleration is indeed now what's needed to deliver the reform of health and social care. So we look forward to hearing from the Health Minister today. This will be Minister Nesbitt's first appearance before the committee since taking up post. No, yeah. Yeah. Oh yes, sorry. Yeah. We had to change the last one. That's not picking up. So apologies. But the committee is also looking forward to a briefing today from Matthew Taylor, who is the Chief Executive of the NHS Confederation. If we just ask for members' agreement that we issue a press release today outlining the committee's participation at NICON and the committee meeting here today, and the clerk will issue members a draft later today for comment, if that's okay, before it's released. Okay. Also, just to remind members as well, we have had a very busy few weeks, and we've been out and about quite a lot. And last week, some of us visited the Oireachtas in Dublin to meet with there, and we received a tour of the new Children's Hospital and St James's Hospital. And again, I think others would agree it was a really, really good engagement. We worked very closely with them in terms of how we could further explore cross-border collaboration and better use of our resources and expertise right across the island to deliver better outcomes for all our patients. So I look forward to continuing that work as we go through this mandate, as I think there's some real opportunities both north and south that we could capitalise on. And just finally, members, this month is Breast Cancer Awareness Month, and tomorrow is the UK-wide Wear It Pink campaign. So members will also have seen there's some information from Breast Cancer Now on your table. So thank you. So item number 3 then is just the draft minutes from the last meeting on the 3rd of October. That's at page 6 of your meeting pack. Are members content with the minutes as drafted? Yeah. Item number 4, matters arising. So just to remind members that the committee had agreed to write to the Minister that he would meet with the Youth Assembly Health Committee on their work on the issue of mental health in schools. And the committee is advised now that the meeting was arranged. So just to update you on that. Okay then, members. We now will have our briefing from Minister of Health, and in attendance also with the Permanent Secretary, Peter Mace. You're both very welcome, and we really appreciate you being here today. I think for this event, for this meeting, it's very good to have you both here. I just remind members that the papers for the briefing are from page 17 of your pack. So there's a departmental briefing paper, the report, Hospitals Creating a Network for Better Outcomes, the most recent Delivering Together report, and the draft programme for government. We have approximately an hour and 30 minutes for this session, and it will be covered by Hansard. And I will remind members, today's session we are very time limited, so I will have to be very strict on questions and contributions. So I would appeal to you to work with me, because I know our next briefing, Matthew has a certain time to be away for as well. So we want to make sure we get the best out of both. Okay, so thank you both. So if I could invite the Minister to make his brief opening remarks, and then we'll open up to the members. Thank you.
Chair, thank you very much. It's good to be here, and apologies it's taken so long. At the risk of delivering a kind of John Hume single transferable speech, I think it might be useful actually to return to my first remarks as Health Minister in the Chamber, and in doing so I want to pause and just pay tribute to my predecessor as Minister of Health, Robin Swan, and I really welcome and encourage him in his new role as a Member of Parliament to continue to promote our HSC system in the House of Commons. Robin and I will continue to press the UK Government to acknowledge that our shocking rates of poor mental health and well-being are to a very large extent a legacy of our conflict, and therefore they are deserving of investment and support. And that funding, if it were to come, would have no repercussive consequences for England, Scotland and Wales, because this is a population health issue for us alone. Now, back in June, if you recall, I asked members to imagine a blank map of Northern Ireland with no health service. And question one was, do we want one? And question two was, why? And there were at least two answers to that: to keep people healthy and to cure the sick. And that takes us immediately to a judgment call, because even if we had unlimited resources and funds and workforce to help keep the healthy, people would still get sick. So we'll always need buildings, large acute hospitals, we'll need technical equipment, medicines, and we will still need the highly specialist healthcare professionals. And what Professor Bengoa reminded us last week is that the only sustainable future lies in what we call the shift left, delivering maximum care in the community and not in our hospitals. So in my world, if you need access to healthcare, the ideal is you get it at home, and if not at home, as close to there as possible. The second worst thing is to have to go to an acute hospital, and the worst outcome is to go to an acute hospital and stay overnight. And I've articulated that vision many times in front of people, including trust chairs, chief executives, surgeons. Nobody has disagreed, even privately. And I was comforted by the fact that the Professor confirmed we are not an outlier in terms of our issues. The challenges we face in healthcare are the same challenges faced by governments around Europe and beyond. And to tackle the incorrect belief that the Bengoa report has been on the shelf gathering dust for 8 years, I'd like, Chair, to give you some examples of progress. For example, multidisciplinary teams in primary care. And I would suggest that MDTs are the shining light of reform to date. Rapid diagnostic centres providing early detection amongst many with only vague symptoms who might otherwise have lived with those symptoms to their disadvantage. The creation of high-volume day procedure centres and elective overnight stay centres. And in relation to urgent and emergency care, an area which this time of year sees further pressures, Phone First, urgent care centres and direct access pathways have all been introduced. And on an issue very close to my heart, we now have a mental health champion and a regional mental health service that's driving through joined-up working across key partners. And of course, none of this would have been possible without our willing and exceptional staff. Progress has been made towards stabilising our workforce compared to where we were, say, a decade ago. In recent years, there's been an increase of just over 1,000, or an extra 27% in medical staff, and an extra 3,000, or 21%, in registered nursing and midwifery. The committee will be aware of the reduction in spending on agency nursing staff, and I've now asked officials to move at pace and be similarly ambitious in tackling the unsustainable expenditure on medical locums. But members, you don't need me to tell you our workforce still bears the painful scars of repeated recent industrial disputes. And I want to help my ministerial colleague, Conor Murphy, in seeking to define a quote-unquote good job. For me, it's a job you look forward to when you wake up, a job you enjoy, which offers you appropriate pay scales, good terms and conditions, work-life balance, where you feel respected and cherished equally by your employer, your peers, and those you serve. That's my ambition for our staff. One way to shift healthcare delivery from hospitals to the community, that is my ambition, I have to say, Chair. I feel I'm going on perhaps a little bit too long, because you did ask for brief opening remarks. So what I will do is just say to you, Chair, that I look forward to working with the committee. I understand you have a dual role. You have to hold me to account. You must also, of course, advise and assist me where possible. And I wish you well in both, and I offer sincere willingness to work with you on those fronts. You're aware of my passion for tackling health inequalities, and I would welcome your advice and assistance with an aspect of that, and that is alcohol misuse. I've asked officials to progress work on the introduction of minimum unit pricing for alcohol, something I would like to achieve in this mandate. And to my mind, this would complement the tobacco and vapes bill that's about to go through Westminster. Both can be key contributors to tackling health inequalities. Alcohol pricing can only progress with executive approval, and I'll engage ministerial colleagues in due course. If approval is forthcoming, I'd like to work with your committee, and in particular, I'd welcome your advice on where to fix any minimum price. It might be 50p, might be 55p, might be somewhere else. But, Chair, figures indicate alcohol misuse costs Northern Ireland up to £900 million a year, and that's never minding the devastating impact on individuals, families and communities, and indeed the stress on our health service. In 2022, 356 people here died from alcohol-specific causes, and that is the highest total on record. And in terms of health inequalities, deaths are up to 5 times higher in the most deprived areas. So, Chair, we have significant research from Scotland that shows the empirical benefit of minimum unit pricing. Happy to share that with you, and of course for on the subject. So that's my opening offer of what I hope will be collaborative working, Chair, delivered without prejudice to your ability to hold my feet to the fire. And I'm, of course, more than happy to take questions, particularly if the answers begin, the Permanent Secretary is a renowned expert in that field.
Thank you, Minister, and thank you for keeping your remarks brief, because it does give us a good opportunity to open the discussion up for as long as we can. And I think you've alluded to your priorities around health inequalities, and that's something that we've been talking about quite a lot, particularly since you've come into post. So it is good to hear that there are some proposals coming forward, particularly around alcohol, and we did do some previous work on the tobacco and vapes bill prior to the general election in Britain in July. So we would be keen, I suppose, to pick some of that up, now, especially now, as we see in the south of Ireland, they are pressing ahead. So in terms of alignment and ensuring that we're all on the same page, I think that is good to hear, and I suppose that feeds into then how we tackle some of the causation of ill health, and it was discussed at one of our sessions here yesterday with some representatives from parts of the sector around, what work we can do around that. So that is definitely good to hear. Minister, we have a number of written briefings as part of the papers provided from your department. I'm going to maybe go to Professor Bangoa's report on the systems, not structures, and just in term following on from the conference last week. And I think it's safe to say it was a very good conference, and there's lots coming out of it. And I think we're keen now to see that acceleration of change. So I suppose, what we've heard very clearly is that we know that every hospital cannot deliver every service. But I think, however we try to do this, and this will tie in with the hospital reconfiguration report as well, and obviously the public minute, we have to ensure, as Bengoa said himself, that this is workforce-led and patient-led as well. So in terms of that engagement, how do you think the department can ensure that those voices are heard throughout the process, so that people are part of the process and have a real stake. Because we have seen examples in the past where people don't always feel that, or they don't. I suppose something that came out yesterday in one of the discussions that we had was even in terms of understanding consultation questions and what that means. For me, how we work with people is showing them what exactly they're getting and what that will mean for them when they need healthcare, social care. So just to get a wee bit more about that in terms of the meaningful co-production, co-design and that engagement.
Well, I think that is essential, because if you want success, you need to bring people with you, and you look at stakeholders. So you do have the workforce, you do have the community. I think I said before in the chamber that I think we all have to recognise that potentially at times when you're trying to affect change, that there will be tensions between certain communities. So, for example, clinicians may say the best thing to do is X, and X may mean consolidating a service from maybe 2 hospitals into 1. But if it's moving from 1 hospital, then the people who use that hospital may feel that something is being taken away from them. So you have to manage that. And what we're trying to say is, if that is happening, so for example, let's take a live example. The Northern Trust are consulting on general emergency services, moving from the Causeway to the Antrim. Now, I've spoken to the clinicians, and to be fair to the Northern Trust, they've had the courage to say, this is our preferred option out of the range of options. So what you could say there is, yes, we're taking something from Coleraine and moving it to Antrim, but what we're going to put into Coleraine is actually better, and that's an elective overnight stay centre. And if you separate out emergency and elective or planned surgery, then you take away the risk that somebody who's been waiting a long time for his or her elective surgery, waking up on the morning of the surgery and getting a phone call to say, I'm sorry, we have to postpone because there's emergency and the surgery at the theatre is in use. So how do you persuade people who feel that they're losing something, that they're not losing out, that they're getting something better? That is the challenge. Mm-hmm. And it's just constant communication and honesty. You've got to be honest with people. You can't have an acute hospital at the end of every street, and I think people have now got their heads around that. Mm-hmm. So the document that I've already published, which is the high-end precursor to the more detailed document, is making clear that I understand people think of the health service as personal and it's local. So you want your local hospital to do everything. People are now, I think, realising that's not possible. You have to have a network. So I grew up in the shadow of the Ulster Hospital, and I wanted to do everything. It's an acute hospital, but when I needed a pacemaker and a defibrillator, I had to travel. Not very far, I just had to travel across town to the city. But then that brings up the question of, it's easy for me because I've got a car, I've got friends and family who will drive me and bring me home. So how do we look after the transport arrangements? So it's being honest about what we want to do, why we're going to do it, what issues that is going to bring up, such as transport, and having that constant communication and engagement with everybody who's going to be affected, whether it's residents, whether it's patients, whether it's service users, whether it's staff, the workforce.
No, thank you for that. And all those discussions then happen across government. So you referenced transport, and for a lot of people that is the biggest issue in terms of the infrastructure. And we've seen the recent issues around the emergency general surgery at the SWA, which was a service collapse, as you know, not planned change, and the concerns and the anxieties that brings, and I've examples in my own constituency as well in Uri. So I think for any planned change that needs to happen, that has to be a discussion around. It's okay, yes, it has to, it's part of the transformation, but is it accessible to people? And that includes staff, because a lot of staff then maybe have to move sites or whatever. So is that part of the current discussions or part of the engagement that's happening?
Well, it is, and in terms of the plan that we put out, in terms of trying to create a network for better outcomes, I think there was much more detailed consultation than has been part of the public narrative. I mean, I've heard comment in the media which kind of suggested that there wasn't detailed comment. But actually, I think we did well in terms of trying to engage stakeholders. And when we go to the more detailed, the 3-year plan, I mean, any specifics will require public consultation. And as I say, I go back to the point that if you can bring the maximum number of people with you, your chances of success are at their highest.
Yeah.
So I have no desire to do anything but have fulsome consultation with everybody who will be affected.
Okay, well, thank you. I suppose then the other thing for me is around the workforce, and as you know, and we have had numerous discussions around this as well, that will be key to both hospital reconfiguration and our delivery of services in hospitals, but most importantly, I think, is also that community and outside hospitals, that we are seeing a real shift in the focus of that early intervention and prevention. And what we've seen to date, given the challenges in our workforce, is that services have become, I mean, children's social work teams, for an example, nursing teams, etc., that it's becoming really, really challenging. So in terms of the plans and where we're trying to move forward, what work do you think still has to be done, or what work is happening in relation to that? Because I think if we don't get that part right, then everything else will fall to the wayside before we even get there. And there's huge challenges right across that sector.
Yeah, I see two things, Chair. Part of it is about doing that shift left, trying to get care out of hospitals into the community. So you're talking about primary care and social care, and I think I'm very, very keen on social care. And just to send a signal out on my first day, when I was encouraged, ministers normally go out and be seen to be out and about, and the Ulster Hospital is just around the corner from the department, and I said, no, I don't want to go to a hospital, I want to go to social care settings. And there's a huge challenge in terms of the workforce delivering social care, and I've heard from many members of the Legislative Assembly, apart from other groups, of burnout within social care. So we have to be well focused on that and make sure where there are vacancies that we move at pace to try and fill them. The other thing which I think about a lot is this idea that the workforce has increased across health and social care, but is that reflected in productivity and efficiency? And it draws me to the conclusion that we are asking an awful lot, particularly of the geographic trusts, because at the one hand we're asking them to make unprecedented savings. We're talking 200 million in one financial year. That is absolutely unprecedented and a massive challenge. But at the same time, as me asking them to focus on that area, I'm also asking them to focus on productivity and efficiency, which is an entirely different area of work. But we need to do that, because if you are expanding your workforce, the logic of that surely is that you are being more productive and efficient.
No, thank you. And I suppose just my final question, and I'll open up to other members. It is on the back of that, and trusts are in a difficult position, having to make really unheard of savings. So I think even your recent announcement around the breast cancer service shows of what can be done. So is there further consideration around that kind of regional approach to ensure, and that's around waiting lists, particularly around red flag cancer referrals and things like that are time critical? So in terms of looking across trusts and working, and as well as that, looking on a cross-border basis, because as I said earlier, we see really good examples of how that's already happening. And I think when we're focusing on the best possible outcomes for patients, we have to look at every option available to us. So is that something the department are currently doing?
Well, actually, the Permanent Secretary is a renowned expert in this field. But what I would say, Chair, is, when I went into the role, I looked and I thought, why have we got 5 geographic trusts? We're quite a small geographic location. We're 1.9 million people. Would we be better off with one geographic trust? And I quickly realised that actually ordering that, or sort of saying I want to move to that position, would soak up so much resource and energy that it would become something of a distraction. And then I thought about some of the big restructurings that have taken place. So, for example, we moved from 26 local councils to 11. But the question is, did we see the savings that we thought that would follow from that? The answer is no, absolutely not. Look at the Assembly. We moved from 108 MLAs to 90. Are we better off because of that? I'm not sure we are. So I've said to the chief execs and the chairs of the geographic trusts, in my mind, you are one. And I don't want you to compete, I want you to collaborate, and I want you to cooperate. So let's look and find where there is best practice, and when there is best practice, let's roll it out to become common practice. Let's learn from each other. And it seems to me it would do no harm if different trusts were the recognised leads on different procedures and policies. Peter, do you want to?
Yes, certainly. So to give a few examples where things are being looked at a regional level, at the moment there is work going on in terms of review of neurology services, and depending obviously on the views of the Minister, that may be something that we're able to put out to consultation later this year. There's work not so far advanced, but again in progress in relation to a review of stroke services. And each of those reviews needs to engage all of the clinical leaders in those spaces before it's mature enough to bring to a public consultation. Similarly, to sort of dive into even more detail, as it were, the department commissioned a report from the Get It Right First Time team in relation to urology services. And what that suggested was that there should be more subspecialisation between trusts as to the nature of the procedures conducted in the urology specialty. So what that, I think, begins to show is something of the complexity of this field, and the fact that it is right to say that we should look at regional solutions where regional solutions make sense, but each of those needs a significant piece of work to be done to be able to bring forward proposals that will work and which will withstand the scrutiny from this committee and from the public as well.
Okay, thank you both for that. I'm going to open up to members, and just for anyone that came in late, we're very time limited today, so there's probably about 8 minutes each for questions, and I will stick to it just so we can get to our next briefing as well. So appreciate members to appeal to restrict to that. My first one is Colin.
Oh, thank you, Chair. Minister, thank you. Minister, you're an excellent communicator. I'll give you that. You were many years involved in an industry where you had to communicate. But if we take a realistic look at where health services are at the minute and just take some of the issues, you announced the other day that there's £200 million stripped out of our trusts. Primary care budgets are reduced. Dentists tell us that they can't afford to do treatments. Vacancy levels across social service settings in some areas are as big as they've ever been. Community pharmacies regularly tell us that they either have to close or that they can't afford to do what they're doing, where they're actually having to pay for the actual drugs themselves. Consultations that take place in things like public health are telling us that it's an absolute disaster. People don't want to be involved in it. They find difficulties with it. There's industrial action on the horizon again. Waiting times are longer, ED waits are up, ambulance waits times are up. And I was at the Mongola conference that was there last week, and I can say I heard a lot of words, but I don't see the plans. And I'm not suggesting that you're going to, in a couple of months, get all of that right, but there is a disconnect at times between the inputs that we get from department officials at committee, the inputs that we get in the Assembly during debates, and what we actually hear from the sector. And sometimes I tend to put a wee bit more weight on what we hear from the sector. These are registered groups, headquarters bodies that are telling us that things aren't rosy, that things are really, really difficult. And yet, whenever we get some inputs at committee, you'd think there wasn't a problem at all. And I suppose if we look at the overall issues that we have, is there any work towards trying to put a timetable, even if it's 10 years, whatever amount of time it is, to try and fix the problems? Because I don't know if we actually are getting a handle of any of the problems that are there. And you're not Superman. I don't expect you to have done that in a short period of time. But it's maybe just that dose of realism that there might need to be.
Well, I do try to balance realism and acknowledging and talking about the real issues that we face, the real challenges that health and social care faces, with trying to be optimistic and trying to put a little bit more hope into healthcare. Because I don't buy into the narrative, the fatalistic narrative, that the National Health Service is plummeting irreversibly towards collapse. Yes, there are. You can list, and you have done, a long list of issues, but you've got 70,000 odd people delivering healthcare, and I'm not going to disrespect the effort that they put in day and daily, and the tremendous results that they produce, which go largely unnoticed. I mean, they're not going to make headlines in the Telegraph or on Radio Ulster. Of course, they're not going to. And I think there are some plans, because I have published that plan about let's create a network, or think of our hospitals as a network to deliver better outcomes. The breast cancer is now a work in progress, and we start with a regional booking system, together with a broader review of how we deliver that. So I think there are things that are happening, and I can tell you, I expect or hope to be Minister for another couple of years, until May 2027. I have no expectation, even if I stand and I'm lucky enough to get re-elected, that I would become the Health Minister again. But at the end of that period, I hope we can all look at the health service and say, yeah, it's at least a bit better. Not totally fixed, but a bit better. And really importantly to me, that the next minister coming in looks at the direction of travel and says, that's the right thing, that's the right route, and we need to continue to follow that route, rather than say, stop everything, we're going to start again.
We have set out plans in a range of areas. So there is a 10-year mental health strategy, there is a 10-year cancer strategy, both of which have clear funding streams set against them. Our challenge at the moment is we don't have clarity about what finance is going to be available for the future. The Minister is developing a 3-year plan, which will set out in a range of different areas what we think is achievable in that sort of window for the rest of this mandate. But we are going to have to prioritise. If we try to solve every problem, then we'll end up solving no problems. So, I know there's always other things that we could be looking at, and we regularly respond to motions in the Assembly and beyond that set out lots of things that we ought to, and we may well agree with many of those in principle, but it's what in practice can actually be achieved.
Yeah.
And I think a partnership with this committee would include us trying to understand and agree what are those key priorities going forward.
So, and money is an issue. We have a 10-year mental health strategy, but if you speak to the mental health champion, who's an independent assessor, she will tell you, in terms of this year's action plans, the budget represents about 1/8 of what is needed. So yes, I'm being realistic about that. Money is an issue, but it's not the only issue. And I have one of my favourite quotes, which I have in my office in the department, is from a writer called Ivan Turgenev, and he writes, "If we wait for the moment when everything, absolutely everything, is ready, we shall never begin." So it's an imperfect world, and you do what you can.
Well, I think you kind of highlight the issues there by detailing, for example, a cancer strategy and a mental health strategy, and we can't get the funding for it. Do your executive colleagues, are they supportive of you? Because we always end up in this position where there's lots of people in the chamber asking for things to be done, but it's you and your executive colleagues, they're not giving you the money to do it. It just seems like we've just invariably go round and round in circles. Can we please have more money to do this? No, but we want you to deliver more services. I mean, how are you going to be able to deliver that change if you don't get the funding and you're being asked to do lots of other things by the very people that aren't giving you the money?
Well, I think yes, that the colleagues on the executive are supportive. I mean, the First and Deputy First Minister and I have met privately, and I am in no doubt of their bona fides, that they're keen to help.
Any checkbook?
You were in the chamber.
Otherwise, it's just words.
You were in the chamber this week when Diana Dodds brought the motion about breast cancer in her constituency, and you know that sitting on the back benches speaking as individual was the Minister for Infrastructure, and you heard his words about, yes, the Minister for Infrastructure has huge problems, particularly in terms of water. Every constituent is probably in his ear about a pothole in their street, but he was making the point, this is about saving lives, this is about people dying because we don't have services. So yes, I do think I have the support of the executive.
Hope the money comes with it. Thank you, Chair.
Thank you. Nuala?
Thank you, Minister. So far, I have a lot of questions, so I'm going to jump straight into it. And just following on then from the transformation agenda, I do want to ask a little bit more about that engagement piece, because there is a major piece of difference between engagement and co-production. So in terms of the actual action plans that you've just outlined, because we already have the blueprint and I know the media narrative that you're referring to, but in terms of the action plans that you say are being developed, will they be developed in conjunction with stakeholders rather than consulted on afterwards? afterward. And I mean not just like individuals sitting on boards or on work streams, but actually, you know, with the stakeholders, with the Royal Colleges, with those allied health professionals, before it actually then goes out to consultation.
That would absolutely be my intent. And actually, one of the big takeaways that I left this building with last week, having listened to Professor Bengoa, was his encouragement to me and to others when he said you need to be tight on outcomes, but you need to be loose on how you achieve them. So I might say, for example, I want X by way of an outcome, but how you deliver that is not down to me because I'm not an expert. It might be the clinicians, it might be the nurses, it might be the Royal Colleges, it might be the BMA, it might be the stakeholders, it might be the residents in a community where you're trying to make the difference. So absolutely, that would be my intent.
Okay, thank you for that. I think that's helpful. And I also just want to note, I welcome the kind of upcoming plans around neurology, stroke as well. I think it's really, really important that region on a number of different areas, but you also said regarding the shift left and into the community, and in this better frameworks, or in this better outcomes document here, there is the discussion around the triangle approach to community care that leads up into hospital care as the last resort, for example, and it's something that was also highlighted in Bamford back in 2013, Bengoa again. And one of the key pillars around that is community pharmacy, but also GP services. We did have questions back and forth in the Assembly last week, but I just wanted to speak a little bit about last year's indemnity costs to GPs. We have heard, both as individual MLAs and party MLAs, that in terms of the indemnity costs, were they actually ring fenced last year for indemnity for GPs? Or did the GPs have to use that to plug gaps elsewhere? Because that's the feedback that we've been receiving as a committee, that in fact GPs had to use that money that should have been ring fenced to actually plug holes elsewhere, and it didn't actually do anything to help. So you had said in the chamber that wasn't the case, so I thought maybe today if we could have a bit more clarity around that.
Well, we as a department are clear that that money was ring-fenced, that £5 million was made available to GPs for indemnity in this financial year. But it is fair to say that the Northern Ireland GP Committee are taking a different view, and I met them just a few days ago. And we were not able to resolve the difference of opinion in that meeting. And what I have offered, and they have taken away, so they haven't decided. Obviously, they want to consult the members, and that's perfectly reasonable. I've offered independent arbitration. Somebody can come in and can look at the contract and can say whether we are correct or whether they are correct, and their view is that in some way we have resiled on the agreement, and we believe we have not. Having said all that, what we want is a solution. What I want is to make them happy, or happier. And in the meantime, we are working, and we made a commitment to them at that meeting that certainly by the end of this calendar year, and hopefully significantly earlier than that, we will be coming to them with a proposal for the long-term solution with regard to indemnity. Because I do get the impression that it started off as an issue within a basket of issues that were part of the negotiation, and it's almost detached itself now and become a single issue. Do you want to add at all?
No, that's fine.
So it really needs sorted, and it needs sorted quickly. But it's important for me to say that my departmental officials are absolutely sure that they have not resiled from any agreement that was made.
Well, I hope that is the case, but I do think financial records will then show out. But I think what is more important is how we go and move forward from here, and not only a long-term solution, but if there was an incorrect, or I'm not saying there was a reneged deal or anything, but if there was, it's how do we make up for that shortfall too? I think that's important. But just staying with the issue then of doctors, and just to add on dentists as well, if you can give us an update on the payment of DDRB to doctors and dentists for 24-25.
At this stage, I'm afraid I would not feel in a position to do that because we need to hear what's happening at the end of the month with the autumn budget
And
statement.
is that something that you have bid for as well in October monitoring?
So,
you waiting for
yes,
the budget?
the Department of Finance is fully aware of the quantum of money we would need to be able to meet the shortfall in services at the moment, funding those services, and to meet in full the DDRB and Agenda for Change pay recommendations.
Okay, thank you for that. And again, I know I'm giving you a lot of questions here, but I'm trying to get them in. Minister, you invited us earlier this week to ask a question for an update on respite services. You know, we have had the Spotlight programme in the past 2 weeks. It's not the only time it's been raised. I am aware that there are multiple judicial reviews in which families took along with other organisations to seek that service from trusts. But I'm also aware as well that this doesn't also start at a young age. You know, I think of Muckamore where they're having their inquiry almost daily, I believe now. And we do see that whenever we don't help families at the very start, that there are some families who are unable to actually continue the care for themselves. They place then their loved one into a facility that then becomes a long-term facility, and that just perpetuates the cycle, and that there are simply not enough spaces. You said that you may have an update, but I'm wondering if you could just clarify that with committee if there is an update there.
Yeah. Well, I want to say that I think, and Peter I think agrees with me, that that the relevant officials have worked at real pace to try and develop a series of options, and I have that, but I've only started to study it today. I've only just been put in receipt of a number of options to try and manage expectations and to be realistic about it. To solve this issue, there's probably 3 areas where you need to put a focus. So there's where the respite occurs. So it's about properties, home, but you need facilities. You need funds. It costs money to do this. And then you need a workforce who are properly qualified. So those 3 areas all need to come together. And none of them is an easy one to resolve, particularly in the short term. But what I would say to you is, I am confident that we will have movement, not a solution, but we will have movement in a very short period of time, and that things will be better by the end of the financial year.
Okay, I think that will hopefully be good news for many families. And just to highlight again the issue of the for-profit independent sector with regards to that care, we are aware with the likes of Rainbow Lodge, for example, they weren't able to attract staff, but when you look further into it, it was because of the wage offerings that there were there for attracting staff. So that's something that really does need to be taken into consideration. And I know you didn't give the outright view at committee earlier this week, but I think it's something that should be factored in as well.
And I think the 3 things go together. So, for example, Professor Bengoa and I, before we came here last week, we visited a social care setting in North Belfast, and we were told they had 5 beds, but only 2 were funded by the Belfast Trust. Well, even if the Trust started tomorrow to fund the 5, the workforce isn't there to man the additional 3. So it's not an easy problem to fix.
But it also a different skill set too, so it's not just social workers in this field.
Yeah.
You can have the youth providers as well. That's also part of the issue too. But thank you.
Okay, thank you. Orlia?
Yes, thanks very much, Chair, and thanks to the Minister for coming along today. I have 3 questions, and I'll just maybe ask them all at once, and you can take note and then come back to me just to allow enough time for the other members to come in. So I'll start off maybe. So the committee, as you'll be aware, has identified children's services and children's health as one of our key priorities, and you'll know that we've been following the Ray Jones recommendations and getting regular updates from your department and from the sector in terms of how that project, those recommendations are being delivered. The Chair had mentioned at the outset a visit that we done last week down to the new Children's Hospital in Dublin, which is due to open this summer, and the joint health committee meeting that we held with the team in the south. And a couple of weeks ago we also held a North-South Interparliamentary Association meeting. So elected reps from across the country met up, and one of the issues that we spoke specifically on was around perinatal mental health services, and how we can hopefully establish better working relations and more services across the island. So on the issue of the children's health, I wanted to ask just 3 questions on that. So if there has been any conversations up until this point with Dublin and the new Children's Hospital in terms of, I think they're going to be leading on like 42 paediatric specialities in that new hospital. So it's just if there's opportunities for if and when sick children might need that help, specialised help, if there's any ongoing conversations around that. You had referenced in the chamber the other day around that there has been conversations around hopefully finding a solution to the paediatric pathology. So you mightn't have anything additional to add, Minister, and I'm aware of that, but even again, if you can indicate that hopefully that is heading towards a positive outcome where maybe, wee babies will be able to and their families get that service in the south as opposed to travelling on a plane. And then the mother and baby unit come up in both meetings with the health committees and with the North-South Interparliamentary Association. And I know that previously we were briefed by officials and there was talk around if we get the mother and baby unit in Belfast first and foremost, or if there's also plans to get one up and running in the south. But then in terms of legislation differences between north and south, if that cuts out any options of cooperation, again, it's just to see if there's any work or ongoing conversations ongoing in terms of that. Then secondly, just around, you have mentioned in your opening remarks around our particular need around mental health and your conversations with the British government in terms of funding. I know you referenced that in your response to one of our debates in the Assembly chamber, I think it was 2 weeks ago. So it's just if there's any update. I know that you're obviously saying that you're pressing the need on the British government for additional funding for mental health. Of course you're making the case with the whole executive. I know that that's happening, but it's just to get a sense of, is that conversation going anywhere with the British UK government? Is there any back and forth? Is there any follow-up? Or, do you believe that anything might actually come out of that in terms of mental health? And then, as Peter had says, with the 10-year mental health strategy and stuff sitting there, so it would be great if there was a possibility that you were getting any additional funding that you could hopefully set aside into that one particular issue. And then finally, on the issue of the health inequalities, again, you've openly, proudly stated that it's one of your priorities as Health Minister, which is fantastic. I wanted to ask if there's been any work carried out or any further detail carried out in terms of targeted screening programmes for areas of highest deprivation. I know you had referenced that. I'm not sure if it was in your speech, apologies, or if it was privately in conversation, but I know one of the issues was around maybe looking at targeted screening for areas that would be more highly deprived than other areas. Thank you.
Okay, I'll kind of go in reverse order for me. In terms of the health inequalities, the 2 demonstration areas for what I'm calling the Live Better initiative have been chosen, not by me. I did not want to risk being accused of any sort of bias, so officials looked at areas of deprivation, and the only thing I wanted was to make sure they were tight geographically, because you've got to be able to show the maximum empirical evidence that you've made a difference. In terms of what goes into those packages, because we're talking about taking services that already exist, putting them into a package and kind of flooding or bombarding these 2 areas with them. Again, it wasn't a question of officials saying, well, we'll do A, B, C, D and F and we'll put those together. It was go into the 2 areas that you're going to choose, speak to the GPs, speak to the community, find out what services they think they would most like to have, and that is what has been done. And I think we're very close to announcing where those 2 demonstration areas will be. And the hope is that we get enough empirical evidence for me to go back to the executive table and say to colleagues, look, we made this initiative, it has delivered. You all know that health inequalities is about 20% health, 40% socio-economic, 10% environment and 30% behaviours. So now, are you going to join me? And we're going to have a sort of holistic all-executive approach for the next areas of deprivation that we go into. Was it the mental health you were?
Yeah, I can pick up on the mental health if that's okay. So you'll understand that any bid for additional funding for health needs to go through the Department of Finance to the UK government, and we will work in that way. So we will not be making any separate case to the UK government. It may be when the minister meets other ministers, he raises that as an issue, but formally we will put any case for funding, and it's therefore the finance minister who will be able to provide updates on where things are in terms of relations with the UK government rather than us, because we won't be directly cited on it.
So my approach is more political than one that Peter would be getting involved with.
Okay.
So, you know, if you take a map of the troubles and put in the hotspots of murders, shootings, bombings and the rest, and then you take a contemporaneous map of mental health issues measured by attempted completed suicide, drug abuse, etc., you've got a match. You know, for example, North Belfast. So I've been making that argument. I've made it to the Prime Minister, to Wes Streeting, the Secretary of State for Health, to the Secretary of State for Northern Ireland. And the reaction I've got is that they were surprised. They hadn't thought about that before, but they got the logic of it. So, to my mind, to get success here, the first thing is awareness. So it's making them aware, the right people aware that this is an issue. And then the second thing is to get them to act. And within that awareness, I'm also saying, well, look, you look at what the last government did with their Legacy Act. They did this unique thing in Northern Ireland, or almost unique. They united everybody against it. So you have got a problem in terms of legacy. And here's something where you can unite everybody in favour of it by addressing that mental health legacy. So those messages, I think, have landed, which is no guarantee that they're going to convert into action, but that's where I am. And to a certain extent, as Peter says, it's outside of the Department of Health. It's an opportunity for the government to say, you know, here's what we're doing with the Legacy Act. But in tandem with that, we recognise you've got this specific mental health need, and we are bringing in an initiative for you, which may be backing the regional trauma network. In terms of the mother and baby unit, we've identified the Belfast City Hospital as the preferred site. We know what it's going to cost, and I am now of the opinion we're going to have to fund it ourselves. In other words, there will be no shared island funding for that. In terms of paediatric pathology, I want to be careful because I have had conversations, but if there is going to be a positive announcement on this, it's not mine, it's Stephen Donnelly's, and I don't want to be stepping on the toes of the Health Minister or the Government of Ireland on this. All I can say is we've had 2 discussions and they have been positive and encouraging. I'm sure the service that's offered at Alderhay in Liverpool is first class, but it's the fact that parents have to travel. And, you know, how can you ask parents to travel further than you can possibly? The shorter the journey and the more private the journey, the better. So I say it's nothing to do with the clinicians at Alderhay. But the difficulty is to attract a paediatric pathologist these days is so difficult, and everybody's concentrating their services. So for me, I'm very much open. If it should come to pass, an all-Ireland solution would be fine, would be very acceptable.
And just on the specialities with the new Children's Hospital, Minister, is there any communication north and south on that, the services that are going to be offered in the new hospital?
I am not aware of that, but certainly I can.
So there's certainly a willingness to look at any service that would not be sustainable in one of the jurisdictions alone, as to whether it would make more sense to do that on a shared basis. Now that could be in Dublin, or it could be in our new Children's Hospital in Belfast. So there's a willingness to look at those, but I think it's fair to say it's a very early stage at the moment, any consideration of those issues.
Thank you.
Thank you. Danny?
Thank you, Chair. I've got four areas of questions I'm going to copy earlier and just knock them out too. First one, you'll not be surprised to hear that staff is a big issue for me, staffing and workforce. Now, I'm glad to see you've mentioned workforce there a couple of times this morning. We all know that without healthcare staff, there wouldn't be a health service. There are significant issues that we've heard again and again at this committee from various corners of the health service. Many of our staff at the minute are very overworked, burned out, and they're staring into a winter where pressures look as if they're going to be a lot heavier again. The programme for government had one line about staff, and it said about investing in our workforce. I think that's the only words about healthcare staff in the programme for government. So I'd like to hear what you're doing for healthcare staff, what you plan to do around fair pay, around safe staffing. I know there's a consultation out at the minute about safe staffing. There's no mention of pay and conditions in the safe staffing consultation. We need workforce planning. What do you plan to do about workforce planning? How we focus that on need and assessed future need. And how you plan to maximise the use of our allied health professionals to strengthen the service. So that's basically my sort of first broad staff question. Number two, the bottleneck, the main bottleneck in our health. We talk about patient flow all the time. We have a bottleneck at the minute where patients can't get out of hospital and where patients can't get in on the other side. We visited the ambulance service 2 weeks ago. Ambulances are stacked up outside hospitals, sometimes regularly for up to 12 hours, and patients can't get in. Obviously, this is a horrendous situation. So it's about widening that bottleneck and what you plan to do about widening it. Waiting lists. One question I've been asked again and again by constituents is about the cross-border initiative. A lot of my constituents are waiting for routine health operations that, if they don't get, their quality of life really gets badly affected by that. And if you've considered the cross-border health initiative being reopened, I know it was very successful when Minister Swan had it a couple of years ago. And the last one is just about the cost of not doing transformation. We talk about the savings. If we don't transform, what is the cost likely to be to the health service, and where do we go from there?
Okay, again, going in reverse order and jump in, Peter, please do. The cost of not doing reform, according to Professor Bengoa in this building last week, is that by the year 2040, health will absorb the entire Northern Ireland executive budget. Nothing for schools, nothing for infrastructure, nothing for nothing except health. So we have to do it. And he did make the point, we're not an outlier on that. That's the same situation for governments across Europe if they don't do the reform piece. In terms of the waiting list and the cross-border, I'm afraid there is an irony klaxon that goes off in departmental headquarters, and it will be ringing very loud and clear at the moment. Because we made a bid for money for waiting lists, including the cross-border initiative, and it was not accepted in the budget. And you know how you voted on the budget. In terms of flow, I think very early, one of the very first days I was in post, I was given a list of potential areas where we could try and achieve these eye-watering cuts of 200 million in trusts. And one proposal was to cut over 1 million hours of domiciliary care, which I immediately thought that is madness, because if you do that, then more people are going to be stuck in beds in hospitals because they can't get home with a package. And if they're there, then the people in the ED waiting to get into those beds are going to be stuck in ED. And if they're in ED, then the people in the ambulances waiting to get into ED are stuck in the ambulances. So the flow is everything, to my mind. If we can get the flow right, then we will see huge improvements. And on the workforce...
Sorry, just with that, what are you doing to improve the flow then at the minute?
Well, trying to release as many resources as possible so that we don't have the blockages. And to me, the big blockage is this idea of we don't have people getting the packages that allow them to go home. Mm-hmm. But resources and funding are constrained, not least because of the budget. So there's only so much we can do. But I do ask people to be as productive and efficient as possible, and to recognise that there is a flow. And we need to address every area where that flow can be blocked. Okay. On workforce, again, I might invite Peter to say a few words, but I've said often, yes, we need buildings, we need equipment, we need medicines, but they're all as nothing if you don't have the workforce. And I do believe that this idea of defining what a good job is really, really important, because it's not about saying good jobs in the health service are about being surgeons or clinicians. Because if you don't have hospital porters, the system breaks down. So it's about this idea of, is it a job that you wake up
So I think we all recognise the real pressures on our workforce, the sense of moral injury among many who work in our system at all levels, because the service that is delivered, while in many cases excellent, there are too many people waiting too long, there's too much unmet need in our system. The approach has to be at a number of different levels. So at a departmental level, we have a workforce strategy. Minister, I think you launched a document around workforce wellbeing a couple of weeks ago, and we are looking to implement that. We are also developing our proposals in relation to training numbers for next year and so on. Then equally importantly, there is within our provider community, within our trusts, the way in which all of the culture of the organisation operates, how people feel in the organisation. I see from my visits and my engagement with trusts how hard they try to create as positive and good a working environment as possible. But there's no doubt that if you work in areas that are under huge pressure every day, however hard you try, that is a very difficult thing to achieve. So I think part of the answer to the workforce problem is how we turn the curve in some of the wider problems that we've already been talking about today. We would be naive to think that we can resolve those workforce challenges while the really big problems that are facing our health system remain in place. You mentioned AHP specifically. I mean, I think that it's a very diverse area, 14 different specialties coming together to form our AHP workforce. I think there are certainly some more opportunities, and actually anyone who was in the auditorium yesterday will have heard me quoting one particular example, but we know there are ways in which we can use skills mix better as part of our workforce, and so that is part of our ongoing efforts in relation to efficiency and productivity, and no one's pretending we've got to the end of that particular equation, but that was one of the points you raised, I think, specifically.
Just on the two other points I raised on fair pay and on safe staffing was the safe staffing.
On safe staffing, there's proposals under development in relation to legislation for safe staffing that are being done on a co-production basis with trade union colleagues, and they will obviously come forward when they're complete. The pay issue, I think the Minister sort of has addressed essentially in relation to, if you're talking about 24-25 pay in particular, where we're waiting to see the outcome of the Executive's deliberations in relation to the Barnett consequentials that are being held at the Centre at the moment.
Okay, thank you. Diane?
Thank you, Chair, and thank you, Minister, for coming. So I want to just ask a series of questions, and the longer I've listened, the more questions I've added to my list. But anyway, we'll try and get through some of these. So last week at the Bengoa conference, I was a little underwhelmed. It was a very interesting presentation, but I was underwhelmed. And I did ask a question, which I think I got, if you were in your former journalistic career, might say, was a politician's answer to the question, which was, I asked, if we are to undertake reform, do we have enough capacity in the system to undertake reform and clear the backlog? Because we have patients waiting years upon years for hospital procedures. So do we have enough capacity to undertake reform, which would be significant, and I hope that this committee can support you in your proposals for reform and clear the backlog.
All right. Do you want this one first?
Yep, thank you.
Well, an absolutely massive challenge, and in terms of our current budget, you would be pushing me towards a negative response to you. But we're trying to be imaginative. So, for example, we have put in a bid to the Northern Ireland Transformation Fund, for the rollout of multidisciplinary teams. And we're still in the game. We certainly haven't been knocked out there, but I don't know whether we're going to be successful in that bid or not. But that releases, if we get it, new funds, which means we can start that process of transformation. But I would also say within limited budgets over the last number of years, we have managed to initiate some degree of reform, and I listed some of them in terms of the rapid...
I want to ask you some questions about them as well. So just if we just proceed on. So do you have figures which tell us at what capacity, at what rate rapid diagnostic centres, elective centres and overnight stay centres are operating at?
Yes.
Mairead, in her response to me, said, you know, our elective centres must become like factories churning out operations over and over again. Is that what we're doing? And are we operating those, you know, on a 7-day basis, or how are they operating, and at what capacity? And are we anywhere near the optimum capacity?
I don't think we've peaked out. No, absolutely not. And I would tell you this: I've had conversations with officials where we've looked at the level of efficiency of some services within these new regimes, and we weren't happy about them, and we took action. And in some cases, we have had very rapid positive responses.
That's actually quite serious and concerning to me. Because if these are the stars of where reform is, and they're not operating at an optimum, I'm not sure how we can actually do reform and clear the backlogs. And we have years of backlogs to clear. Well, can I just, because I'm conscious the chair will start shouting at me very quickly. Health. You also talk about health inequalities, and I agree with you. And you know, in my lifetime, I've represented some of the most deprived communities in Northern Ireland, and I don't take away from that, and I'll be really interested to see the outcome of that. But there are huge structural inequalities in our health service. And when I had the debate on breast cancer services, which I thought was a well-conducted, good debate on breast cancer services, and I'll just, for the sake of the room, also demonstrate those inequalities, because they do really, really concern me among trusts. In the Southern Trust, about 10% of women who discover a lump in their breast are seen within the required time. In the Western Trust, that's over 80% of women. In the South Eastern Trust, where we are now, that's just over 4% of women. And in the Northern Trust, that's just over 7% of women. Those are utterly appalling statistics. And it's that differential of service that women are getting. And I know you have launched the review, but the breast cancer is but one of many services where there are those differentials within trusts. So my question is, how do we actually sort that out? And how do we make trusts accountable to sort that out? And if we are going to give trusts the say on which services are delivered in which areas, how on earth can we do that when we already have these existing inequalities?
Well, I've already said, I think that what I want to do is identify best practice, and that might be best practice that is discovered elsewhere outside of the 5 of our own geographic trusts, and make that common practice. But I have to go back, Chair, to say, in terms of not being 100% efficient, you can't expect 100% efficiency. There will always be, particularly in terms of lists, delivering lists, there are always going to be occasions where somebody is unavailable because of perfectly understandable last-minute reasons. And if one key person is missing, if it's the surgeon or the anaesthetist or a theatre nurse, then that list falls and your 100% becomes 90, whatever. What we are trying to make sure is that where lists are cancelled, if there is a reasonable opportunity because somebody has dropped out to replace them, that happens. And we're making very good progress with that. But I return to the point, what is best practice? And how do we make it common practice across the piece? And I accept, and you know I accept, some of the really unacceptable levels of performance, not just in terms of breast cancer.
How do we get accountability for that? Because it seems that we wring our hands and say this is terrible, but we need accountability for that. This is about women's lives.
The buck stops with me.
And so there's a performance management approach taken within the department through our strategic planning and performance group. And what they have set is a 5-stage escalation process through which, if trusts are not delivering against, and they believe that the reason for delivery is not a reasonable one, that there can be an escalation process through that. So that is the accountability mechanism. It's based very closely on what exists, I think, in Scotland. And under that mechanism, you would only be drawing out those who get to level 4 and 5 into the public domain. You'd be looking to work within the system to try and address the problems at levels 1, 2 and 3. So that's the performance management process that we go through, whether that be for breast assessment or any other service that is not delivering against. Now, as the Minister said, there may be occasions when the performance, while the numbers aren't right, the Trust has no obvious way of being able to rectify that situation. We need to be sensible about the approach we take. You can only hold people to account for things they can reasonably be expected to resolve and address. So that's the kind of mechanism that we can use.
So would it be possible then to write to the committee and tell us how that accountability mechanism works and which trusts and which services that you're currently working with, particularly those that are in danger of going into levels 4 and 5?
So there are no services currently at levels 4 and 5.
Okay, right. It'd be interesting.
It's a relatively recently introduced system, so it's a system we've been introducing in the last few months. So it's something that we're still growing and developing, but it's a different way of trying to approach
I would be
the performance
interested
equation.
in further information on that, because I do think that we do have to make people accountable for that really, really poor performance in an area that is very time critical. Just 2 more questions before I've finished. The PEG, those children who are still waiting on PEG surgery, there was a bit of an initiative in October. Will that continue? And how do we resolve the issue? Because I do have an email from parents who say that even though this initiative took place, 8 more children were added to that list in October. And my last question is in terms of capital budgets. What capital bills will not go ahead because of the huge overspend at the maternity hospital? And is there any sense of what the department thinks will be the remediation costs?
Okay, in terms of the PEGs, keep me right, Peter, I think there's just over 80 children on the list. It only happens at the Royal Belfast Hospital for Sick Children. There is a review of that list underway. There are also negotiations going on to see whether it would be possible to also offer that service at the Ulster Hospital, which will require a degree of staff training before that could be undertaken. Is that about?
And I think there has been a reduction in the number of children awaiting the surgery already, as I think you highlighted, and there are plans to continue that. I think it's always important in relation to any one procedure not to look at that one procedure in isolation, because children, some children have complex needs that it's not purely around the one procedure that is going to meet their needs, and there may well be other procedures that the same group of surgeons and nurses are responsible for, and by focusing entirely on one service you can then lose sight and just create a different problem elsewhere. So I think you do have to look at the overview of the position as well as the specific issue that you've raised previously.
I'm not aware of any capital projects that...
So the way capital works is you get a capital budget for each year, and the changes in the spend for the maternity hospital over a number of years have been accounted for in the spending from those previous years. The total for the remediation costs will depend on the outcome of 2 reviews that are being conducted at the moment by independent experts, one from Porton Down and the other from a firm called Hydrop. And we hope that in the next couple of weeks, the Belfast Trust expect to receive the final reports from both of those independent experts, and that will then enable a proper judgment to be reached about what the right remediation steps are.
Okay. Alan Robinson?
Oh, thank you, Chair. Thanks, Minister, for your input today. We really do appreciate it. There are times that you maybe feel that we are in some way negative towards you or in any way attacking you in any way on the floor, but we're not. We recognise the difficult challenge that you have and your department has. And I'm pleased, Minister, that you did touch upon in your earlier communication about the importance of public messaging, especially around reform. And within our introduction today, within the report, it does make reference to how the department recognises the importance of engaging the public and strives to ensure that engagement, consultation and public messaging is timely and appropriate. And it was you who raised it with regards to Causeway. Do you recognise that over a period of years, and forgive me for bringing it down to that level, but over a period of years, there has been a series of poor messaging around that hospital, not just in recent weeks and months. There has been a mantra over a significant period where there was a vision for Causeway Hospital. In recent weeks and months, we've heard about the elective hub, but yet we have no meat on the bones. And the people who I represent, not just ordinary members of the public, former staff clinicians, senior clinicians, who are concerned that move emergency surgery and push it towards Antrim, that you are kicking away a key pillar. So whilst we have a series of services being removed from Causeway Hospital, and all the while we're being continually told that there will be services coming to Causeway Hospital, but we haven't seen them. And I suppose the question is, when will we see that detail? And I know there has been an announcement about an MRI scanner. For me, that's 10 years too late. That, for me, is not the good news. Well, it is a good news story, but we want to see the meat and the bones. And you will understand that it's very difficult for me. There's a lot of chat about leadership and showing leadership, but it's very difficult for me whenever you go into a public meeting and it is not members of this language, people with pitchforks. It is people who serviced that hospital for 25 years, respected people who, members of the public who are there and who were prepared to give trust to those staff members with their lives, and to hear those former staff members saying those things, that is a key pillar that has been kicked away. So what would you say to those senior clinicians who worked in Causeway Hospital over all those years, who attended the session, the listening session, back just last week or the week before, and who made their feelings very known? I know on the floor, when I had asked you about Causeway Hospital, you told me to speak to clinicians. I'm speaking to the former clinicians, and they're very concerned. I can also just ask the question around MDTs. I know you did touch upon that, and it is a good news story. Every time we talk about the bad news stories about the health service, but MDTs are a very positive story. Evidence is there that there has been no GP surgery that has handed back their contract who's had a full complement of MDTs. When do you envisage that, or is it possible to see a full rollout of MDTs, or am I asking for the moon in the sky?
Well, at the moment, I cannot say to you the rollout of MDTs will go from 7 to 7, the full 17 federations by X date. But hopefully the next 3 federations will get their rollout of MDT if and when we're successful in terms of the bid to the Transformation Fund. So that would be relatively quickly. In terms of your points, I just want to, before addressing kind of the past, I did say in my first remarks in the Chamber I was never going to criticise a former health minister. I don't see the point of that. I mean, if criticising a former minister was going to improve the prospects of a single patient, I would certainly think about that. But it won't, so I'm not going to do it. So I'm just going to accept you know, you're giving me a perception that there's been very bad communication in the past about the hospital. I've got to accept that as a very valid perception within the people that you represent, and that's fine. I have spoken to a former surgeon who is very much against moving general emergency surgery down to Antrim, and I have listened to him, and he's passionate about the hospital where he worked vocationally for all his career, and I respect his opinion. But the clinicians I've spoke to who are working today for the Northern Trust are saying it's not. I know the Trust are saying this is our preferred option. They're saying this is the essential option to prevent collapse of the service. And I think what we always need to do better is say, if and when we move a service, you're going to get something better in its place. And that's difficult because that's basically prejudging the outcome of a consultation. So I understand why we've got a difficulty there. But I want people to understand that my motivation here will be a number of steps, all of which is part of creating a new jigsaw which will ultimately be about delivering better outcomes overall. And that will include a degree of pain for people, because nobody likes to lose a service. And I can understand, you know, you look at that in isolation, think I'm losing a service, that's bad. But then you also think about, is this part of a continuum? And are you actually running down this hospital to the point where it becomes unsustainable? And that is certainly, absolutely not my motivation. The Causeway has a future. And I think if you make it an elective centre, then you've got a bit more certainty about it. And I go back to this point about you don't get cancelled because there's an emergency that's gone into the theatre. So, yeah, change is always going to be difficult. It's always going to be very, very challenging. And I do understand that, you know, up on the North Coast, you've got a particularly ageing population because you've got people who, you know, relatively high wealth retire and they want to move somewhere like Portstewart, Coleraine, up into the Triangle. So we have to be, and I am conscious of all these things. Ultimately, there's going to be an element of judgment call in every decision we make, so you can't keep all the people happy all the time. But I will be guided primarily by the clinical advice and then determined to go out and try and persuade the community that's affected by that this is a good thing for them.
MDTs?
So I think the Minister said we couldn't guarantee, but it's a high priority for us in terms of transformation and reform as to the steps we would like to take. It will be funding dependent as to how quickly we can make that progress.
Okay. Thank you, Alan. And Alan Chambers, thank you so much for your patience.
Thank you, Chair. Minister, I think we can all acknowledge that setting the executive budget this year has been an extremely difficult exercise. It's been fraught and even divisive. What approach would you like to see adopted in setting the budget for 25-26? Hopefully the executive departments are soon going to be engaged in genuine discussion and deliberation on next year's allocation, rather than leaving it to a last-minute rush that has unfortunately been the case in most years recently. And are you optimistic that the executive will ever get around to setting multi-year budgets that could offer everyone more certainty and assurance, particularly in your area of responsibility?
Okay, thank you. 2 points, Sarah. Again, I'll go in reverse order. Yeah, I am very optimistic that we're moving towards multi-year budgets. At one point, I thought we might even get there as soon as next financial year. I think it's probably going to be financial year 26-27 when we've got a properly embedded 3-year budget, and that's because we've got a new government in London, and I don't think they're quite ready to go to multi-year next April. But I am very optimistic, and that in its own way will be transformational in terms of how we deliver healthcare in Northern Ireland. On the other point of your question about collaboration, effectively, I was saying actually in the conference hall earlier this morning, introducing the First and Deputy First Ministers, I've been in MLA 13 years, which is about half the time that the institutions have or have not been up and running. And I sensed in February when we went back in, there was better atmosphere. It's a more positive atmosphere. There's a determination like never before to deliver. And when I sat down for the first time in June around that executive table, I sensed the same thing. So there is a determination to deliver and to work collaboratively. And I've noticed, as we've discussed the budget over the recent months, we're more and more coming to the conclusion that rather than each minister input to the finance minister, these are my concerns, these are my issues, these are my demands, these are my inescapable pressures, that we actually sit down together and we all listen to each other's inescapable pressures. And then you come to a point where you say, well, you know, we have a problem, we can't build houses because the water system doesn't work. So how important is that against the fact that the cancer services or breast cancer services aren't up to scratch? Because we've got to come then to a decision about what are the real priorities given the budget and the resources that we have. And I'm really encouraged that I say increasingly we're recognising that is what we have to do, and that is what we are starting to do. And I would imagine by the time we get to sorting out the next budget, you'll notice there's been a very different collaborative attitude to it.
Thanks, Minister.
Okay, thank you. Minister, just before we finish, because I think we're just on time nearly to the minutes.
The last one's always the tricky one.
But no, look, it's just it's an important issue, and it's something you will be aware of. And we've had a lot of conversation around post 19 for SEN children and young people, and the Caleb's Cause campaign is one that we're all very aware of, and it's led ferociously by Caleb's mum Alma. So I know we had at the recent Learning Disability All-Party Group an update from Nigel Chambers and from your department, and also from Claire Thompson from the Department of Economy. So it was just to kind of see what collaboration is happening with other departments, and are you considering the potential around legislation on post-19 SEN provision?
Well, the Permanent Secretary is a renowned world expert on this issue.
I think it's fair to say we're not currently looking at bringing legislation forward, certainly not in this Assembly term. There are a number of legislative vehicles that we are looking to advance, and I think resources will need to be prioritised to try and deliver against those rather than bringing new things forward. But we can certainly write to you with more detail if you would like it.
I did meet Alma the other day, and I am entirely in tune with what she's trying to achieve. It's just the practicalities of doing it. And again, it can't be just me, it can't just be the Department of Health. But again, there's so many issues that need to be addressed, but that shouldn't put us off getting on with it.
Okay, thank you. Look, thank you both. There's been so many, I suppose, pressing issues that we probably could have done in a full hour, but we'll not put you through that. But anything else we'll follow up in writing. But no, we do really appreciate your time, and I suppose as a committee, as we said at the very start, with both yourself and your predecessor, we are keen to work collaboratively as much as possible. We will hold you to account, but where we can work together, I think, is always better. So thank you both.
No, thank you all. Thank you.
Okay, members, so thank you, and I do appreciate everyone keeping relatively within time there, so everyone got an opportunity to ask questions. We had a good discussion. Our next briefing, then I'd like to welcome Matthew Taylor. Matthew is Chief Executive of the NHS Confederation, and you will see there's a briefing paper at page 138 of your pack. So Matthew, you're very, very welcome. Members, we have 30 minutes in total for this session. So if we could invite you, Matthew, to make some opening remarks, and then I'll open up for questions if that's okay. Thank you.
Well, thank you very much, Chair. And really, all I can say is how recognisable this conversation, the conversation I've listened to over the last hour or so, has been. We face, I think, almost exactly the same challenges, of course, in England, because they reflect some of the same underlying issues to do with the gap between demand and capacity. But also, in particular, I recognise this challenge of how do we meet the immediate pressures and demands on the system at the same time as try to transform the system when transformative funding is not available. And I think that I spoke just the other day to the Secretary of State West Streeting. I think this question of how you respond to the immediate challenges, but even in quite a modest way, you manage to do that in a way that starts to take you towards a different system, is at the front of his mind as well. Because I think there's no question that in many ways, the ways in which we do things are fundamentally problematic. I think the model of care often doesn't work. I think the way we think about risk and safety is not adequate. It means we prioritise certain risks and issues, but not other, actually more important risks and safety questions. So in a whole variety of ways, we could do things very differently. But how it is we start that journey at the same time as meeting the challenges we face today, that I think is the big question. And I'll just finish by saying, and I don't really even speak for the Confed, let alone for government. I think if you ask me where you start this process in terms of prioritisation, I think my sense is that we need to invest more in primary and community, but we need to do so in a way which is strongly linked to demand management and secondary prevention. So we need to make sure that that additional investment is very strongly connected to the capacity of the primary and community sector to be able to reduce demand. And I think we kind of know how we might go about that, but that's, if you said to me, where would you start, that would be where I would start, I think.
Yeah. No, thank you for that, Matthew. And I think that's largely a lot of the conversation we have been having as a committee as well. Yes, that we recognise the need to tackle the biggest issues around waiting lists, which are those real time critical ones that will take the pressure off upstream, or downstream, I should say. And then it's that focus on investing in early intervention and prevention rather than reactive. So I suppose that leads nicely into my first question. So you will be aware then of the proposed health reforms for the North, so around the things that we've talked about even in our last briefing around hospital reconfiguration, elective care frameworks, workforce planning, and that move into better primary care and better community care provision, because that is I suppose the cornerstone of being able to deliver on everything else. I mean, from what you've seen, what do you think looks like it works well, and is there any areas, any concerns or anything that you think there could be improvements on as we start to get into it, based on your own experience or maybe examples from your own jurisdiction as well?
No, I don't want to claim that I have detailed knowledge of the plans and proposals here in Northern Ireland. I can certainly talk a bit about some of the things that I've seen that I think work, or give me a sense of the future.
Yeah.
And you talked about MDTs in primary care. I'm excited by what we call integrated neighbourhood working, which I think is a similar kind of idea, but it goes beyond the health service, engaging the voluntary and community sector. Because I spoke earlier, didn't I, about the model of care not being right. And I think one way to articulate that is that we still have a model which is primarily based upon the idea that the people we care for are people who are well, apart from something being wrong with a part of their body. And actually, as we know, demand is not primarily coming from that. If the health service only had to deal with well people with things wrong with parts of their body, I think we'd be okay. But we're not. We're dealing with people who have long-term complex issues, who often have a combination of physical, mental and social issues. I spoke to a GP a few months ago who said that 1 in 3 of the people coming to see her, really their problem was a housing problem, not a health problem. So when I visited East Birmingham a few weeks ago and I looked at the work that they're doing there, both in a kind of single point of access and a more proactive model, so using data to really understand their patient group, to understand where those patients are in the system, to understand where they are indeed in the flow of the hospital, and in that kind of collaborative working to try to think about how it is we can improve flow in ways which are beneficial for patients. I sometimes worry about the concept of flow because it sounds like we're saying the challenge is to get patients to flow around a fixed health service. Actually, what we want is services to flow around the needs of the patient. But nevertheless, it's very good practice. And then working with that kind of proactive care coordination model, really impressive integrated neighbourhood working. And I told this story earlier, but what I found fascinating sitting in the room with this neighbourhood team, which was a combination of GP, social worker, mental health community worker, social prescriber, social care worker, was the in-depth knowledge they had of their community and the assets in that community. So this was kind of asset-based community development in practice. You know, that there was that in-depth knowledge. But also what struck me was at the end, having watched them really impressively, I mean, they were all sitting in this tiny room with laptops on their knees, so infection control wasn't great, to be honest. I mean, if one of these people gets flu, they're all getting flu. But apart from that, watching them building care packages in real time, discussing people in real time. But at the end of it, I said to them, what is the service you would like more of, if you know, in terms of what you can refer people into? And they conferred for a moment, and they said befriending. And that really struck me, because that's not a health service. It's not really a statutory service. It's really a kind of characteristic of community where voluntary community sector can play an important role. So I think when I see that, I see the beginnings of a more holistic, more proactive model in which not only do we help people as early as we can, but we help them in holistic ways. And I think the other thing I would say around that is that we often talk, don't we, about the problem being demand. Mm-hmm. I actually think very often, particularly in our most deprived communities, the problem is engagement. The problem is that people are not coming forward at the time when we'd be able to help them. I saw another fantastic piece of practice in Norfolk, a little town. The primary care practice had more or less collapsed. The GPs had left. There was just a pharmacist left. And then the local authority, and of course our local authorities in England are bigger, have more scale, more capacity than yours do here, but the local authority and the integrated care system had jointly employed community health workers who proudly wear the badge of the local authority and of the ICS as they go out. They'd identified the most at-need community, and they'd gone and knocked on doors. Now, the two things that are really interesting about this is, first of all, the level of need they'd identified. And it ranged from somebody with a severe mental health crisis who probably would have attempted suicide had they not knocked on the door at the precise moment they knocked on the door. But also they had Afghan migrants who didn't know that primary care existed. They didn't know that you could come along and you could be vaccinated, you could bring it just wasn't part of their kind of cultural background. So they came across somebody who was bringing their daughter into A&E quite often with asthma attacks, the reason being that their house was full of mould, and because it was a joint local authority, health authority initiative, they were able to address that issue. Whereas generally, if you're a GP and someone comes to you and the issue is mould in the house, well, what are you going to do about it? So I think that way of working was really helping those people. But the really interesting thing was that the person who was at the centre of all of this, and isn't it so often one person who's at the centre, said that they were beginning to see evidence it was reducing demand. They were beginning to now be able to see that because they'd gone out and they'd knocked on doors and they'd engaged people, that fewer people were now ringing for ringing ambulances or engaging with the health service at a very late stage. So I think we have to have faith in the fact that if we can develop those different kinds of models, that is part of the way in which... So it's an irony when we often feel as though we're protecting ourselves from this flood of demand, that actually one of the ways we address that is actually to go out and engage people more.
Yeah. No, I think you've summed that up perfectly, because I know we've certainly had lots of discussions around, yes, the need for that, you know, everyone involved. The MDT models as a really good example of having, you know, you have your social worker, your mental health practitioners, maybe the physio, OT, you know, that team of people, so that people are getting to see the right person for their right problem at that time, or their health concern. And you mentioned befriending, and that's a really important one, because I've spoke to GPs recently, and one of the, you know, obviously there's a huge issue, I'm assuming it's right across the board, with access and GPs, and the huge demand on GPs as well, and trying to get through. And sometimes some of the issues are maybe someone who's lonely and maybe their mental health is suffering. And GPs have said to me, we don't always know where to even signpost someone. So even in terms of the demand, and I think you've given a really good example of how that works well, I think that's a lot of what we've been trying to shape in terms of where we go with this.
So I think it's important that those MDTs are linked really deeply into community organisations.
Yeah.
And to just give you one other example of good practice, also I've seen, it was initially done in Sussex, I've seen it now done in another part in mid-Essex, which relates to waiting lists, is secondary care, consultants and GPs, nurses, others getting together, organising days where they invite everybody on the waiting list to a single day with multiple clinicians, lots of advice. And what is very interesting is at the end of those days, generally around 40% of people voluntarily remove themselves from the waiting list as a consequence of the advice that they've been given and choose to self-manage instead. So, these kinds of more proactive methods can be really helpful also in relation to demand.
That's an interesting one, and maybe if we could even get, if it's available, some information on figures around that, and if there was any data around for anybody that takes themselves off voluntarily, do they ever go back on because they haven't been able to manage, or because I would be interested to see, because we have talked a lot around health literacy and people understand how to keep themselves well for longer as well, given the circumstances. So that's something I would be interested in.
So they would tend to use the patient-initiated follow-up model. So they'll be saying to those patients who come off the waiting list, there is a guarantee that if you do feel, if you are concerned, you can come back to us. So that's part of the package. You're not just dismissing people. You're saying to them, okay, have a try at self-managing this, but you can come back into the system if it's not working. No,
absolutely. That's something I'd be interested to hear more about. Thank you, Matthew. Nuala?
Thank you, Matthew, for coming along today to the committee. And it has been a successful 2 days, and it's been great to actually participate in some of the panels and also hear from a lot of your member organisations. I think that networking has been key and invaluable to us as a health committee. One of the issues that I was looking at in the briefing that was provided to us was around the Confederation's role with regards to workforce planning, and I just wanted to touch a little bit, if you could expand a bit on the role with regards to collaborative working, between NHS England and then here in Northern Ireland, especially in particular around the negotiations for pay. I noticed in your briefing you had said that there was a lot of lobbying to get the government back into talks with the BMA. For example, and I just wanted to ask about your role with that here in Northern Ireland, especially with regards to that collaborative piece. When we are seeing deals being made in England and Wales and in Scotland, and then not here in Northern Ireland, what role can the Federation or do the Confederation play?
Yeah, so the Confederation contains NHS Employers, which is the organisation that represents the HR function. So it's it's entirely contracted by the Department of Health, but it's part of my organisation. And you'd get a better answer from Danny Mortimer, who runs NHS Employers, than you can get from me. I think generally our position in relation to the industrial action was simply to say on behalf of NHS leaders that we wanted both sides to enter into negotiation and to try to increase the kind of pressure on them so to do, and but also to articulate the consequences of industrial action continuing. So we studiously avoided taking sides, because that is not something that would help. Although I would say, as the action unfolded, there was a slight shift of nuance in terms of who we were describing as being responsible for it. But generally speaking, our position is simply to try to encourage a resolution. In terms of the broader issue of workforce planning, I think that what we've strongly encouraged is joint workforce planning between health and local government, which is not an issue for you, I think, because health and social care are together, but actually more broadly thinking about workforce planning within a whole area. And this, I think, is important to connect the employment challenge that we have in the health service with the wider employment challenge that we have. And I've seen some really great practice. For example, I was in Durham a couple of weeks ago. Really fantastic work there in terms of outreach into schools and the development of apprenticeship into the health service. there's a well-known, it's dated now, but I suspect it still has some truth to it, a well-known study of working-class boys in the northeast who were asked what jobs existed in the health service. And they said, well, there's doctors, and I could never aspire to be a doctor. There's nurses, and that's lassies' work. And there's porters, and you don't need to be qualified to be a porter. So, and actually I had no idea that there's 150 different jobs, career pathways within the health service. So actually this trust and place had gone out very proactively, working with schools, getting kids, starting in primary all the way through, to recognise those multiple strands and the routes that they can take, and then developing a whole set of apprenticeships at different kinds of levels. So there, I thought was really exciting about it, and I'm going to give you another example as well, was not only were they meeting the recruitment challenge for the health service, but they were doing it in a way which was promoting good work and an inclusive economic approach within that locality. So that's good. And another example I just want to share with you, which I came across a couple of weeks ago, I thought was really exciting, is mental health peer counselling. There's growing evidence of the value of that as an approach. It's has clinical efficacy. It's cheaper than many other interventions. But what's really interesting is that 70% of people who become mental health peer counsellors, who get paid to do peer counselling with people who have mental health issues, were previously economically inactive. So it's again a really interesting example of the way in which we can meet needs in the health service in ways that also contribute to the challenge, which is huge here, of economic inactivity. So I think we could be, when we think about workforce planning, there's a real opportunity to be a bit more imaginative.
Thank you. Okay, thank you. Diane?
Yes, thank you. Over here we have an integrated health and social care service, whereas that is much different to England and Wales. Have you a judgment on how well either of the two works? We tend to think that this integrated system is much, much better. I'm not so sure that it particularly is. And now we have calls for example, children's services to be put into a separate arm's length body. I've just read an email in the correspondence
talking about lack of money, it's a bit of a broken record, but actually one of the things that came out of the Lord Darcy report is that whilst there are issues around revenue funding, and particularly around the kind of short-termism of revenue funding, and it was great to hear the commitment here to multi-year funding, it really is capital investment. There is no question that we are way behind our comparator nations, and that has a huge impact. And when I look at some of the most productive practice in England, it has been permitted by capital investment. Elective hubs, for example, you were talking earlier about an elective hub. Whether it's Chase Farm Hospital. I was at Chase Farm Hospital a few months ago. Where they've got barn theatres. 4 operating theatres in a room with natural sunlight. Incredibly productive. And the Health Foundation has found that those cold sites, those elective hubs, are 20% more efficient than undertaking the same operation work in a traditional general hospital. But it requires capital investment. So capital investment is, I think, the single biggest reason. I think then you've got issues around staff and the mix of staff, the turnover of staff, and staff still quite high levels of burnout, high levels of absenteeism is also a part of this. But I think I would also say that we need to look at productivity at 2 levels. There is the kind of process efficiency, the kind of questions you were asking earlier about variations in performance and understanding those variations in performance. I was at a session first thing this morning here about QI and that kind of improvement. But we also need to be able to stand back from that and ask some bigger questions about whether we're looking at this in the right way. And I talked earlier about risk and safety. And my view is that the way we talk about risk and safety in the health service tends to make it a barrier to innovation and efficiency. But there are different ways of talking about it which could make it a driver of innovation and efficiency. We are, and I understand exactly why this is, particularly from the clinician perspective, when we talk about risk, we overwhelmingly think about risk at the point of, a clinical risk at the point of care. What we don't talk about is the risk of unmet need, for example.
Yeah.
And so I think we could learn, I'm taking this idea from a woman called Rosie Benowith, who runs the Health Safety Investigation Board. We need to take a leaf from industries like aviation that look at safety as a whole, across the whole system, rather than simply at particular points in the system. And I think if we did that, it would reveal the fact that the way in which we allocate money is really not terribly strongly related to minimising harms and maximising the most effective use of our resource. So I think we need to have those kind of standing back conversations about productivity, as well as the kind of more traditional QI-focused process productivity questions. Both are important, but we need to do both.
Do you see AI as a future in that service?
Yes.
Very big questions.
Of course, AI is going to be very significant in the future. I think, first of all, there are a set of questions around data and privacy and all of those things that we've got to get right. I think the public are pretty permissive. They want us to get on with it, but we do need to reassure people about some of that and inbuilt bias and those kinds of questions. I think, secondly, we have to avoid over-promising. And one concern I have at the moment is in diagnostics, that we're seeing lots of innovation in diagnostics, but still these innovations generate quite a lot of false positives. And if you speak to people in hospitals, they're dealing with quite high levels of referrals from primary care. And I was in the dermatology department the other day, 90% of their referrals from primary care are false, are for potential cancer, turn out not to be cancer. So there's a bit of a danger of technology that's quite good at diagnosing risk, but is not good enough at diagnosing the risk out, as it were. So quite a lot of AIs make promises, and actually, when you look at the way they actually apply them, they actually work, they're not actually making things efficient. So AI is an important part of this, but let's be really practical, and let's actually focus where we can on the obvious solutions that make a difference. So I'm very impressed by the use of voice recognition software. I've talked to GPs who, it's a complete game changer. Using this means when they have a consultation, the AI records the consultation, transcribes the consultation. They don't have to write up the notes. The next stage is that the AI then can make the referrals. unlike lots of other technologies, within a day, people are going, I can't live without this. It's completely changed my lives. Whereas quite a lot of technological innovation, you have to go through this big dip where things get worse before they get better. So, yes, absolutely, but let's take it step by step. Let's not be seduced by over-promising, and also let's make sure we get the governance right.
Thank you, Chair. Thank you. Diane, Matthew, I'm very conscious of your time as well, so my last question, I think, is from Danny.
Yep, thank you very much. As a male nurse, I would disagree with your the study of young men think it was less.
Oh, it's their perceptions were wrong. I wasn't suggesting their perceptions were right.
I would encourage any young man to consider a
Absolutely.
career in nursing.
Please understand, I was talking about their perceptions, not.
It's very fulfilling and worthwhile career.
Absolutely.
So I encourage anybody to do it. One of the things we were talking about workforce challenges within the NHS is something that comes up all the time here. I'm just wondering, have your members been able to shape government policy around workforce challenges at all?
Yes, we were certainly part of the very, very long process of convincing the government to sign up to a long-term workforce plan, which finally emerged 18 months ago. I think we're part of a group of people encouraging the government to fully implement that plan. But also potentially, I think there will be a refresh of that plan to maybe be more ambitious, particularly in relation to this question of, I think if I had a criticism of the long-term workforce plan that we've got, I would say it was insufficiently radical in terms of the nature of the patient demand that is coming down the line to us, and the need particularly for more generalist care. So I think there will be a refresh, and I think it's an opportunity to be a bit bolder in that regard. And then, of course, NHS Employers, the organisation I talked about earlier, we do a lot of work with the government on the kind of day-to-day issues that really make a difference to people's working lives, whether it's, prosaic issues like, places to be able to cook food and rest areas, but then more generally very important issues like, for example, equality, diversity and inclusion. And, it's worrying that when you look at staff survey results, which have, to be fair, in the last year have plateaued, some improvements, but still our BME workforce has lower levels of morale and still complains of experiences of racism. So we do an enormous amount of work in the day-to-day way, working with HR managers to explore how it is they can improve the quality of people's working lives. And it's really important in this work to recognise that recruitment is really important, but retention, pound for pound, the money you spend on retention gets you more than the money that you spend on recruitment. And by the way, it's exactly the same with economic inactivity. Keeping people in work when they become ill is an awful lot easier than getting people back into work if they've dropped out of work as a consequence of illness. So when we think about that, and the Minister made this point twice, I thought, very interesting, because of course I did a review on employment for Theresa May about good work. And I think good work is important for us in the health service. I think it's also really important for us in the wider economy, because part of the reason we have such high economic inactivity levels is because, and I was chatting to somebody just earlier today who had mental health challenges about inflexibilities. We really need to work with employers to be able to support people to be able to carry on working even if their health status changes.
Absolutely. Glad to hear it. Thank you very much.
And I want to reiterate, nursing is not just for women. I'm only saying what the boys thought. Yeah, I don't want to be caricatured as suggesting that.
Matthew, thank you very much. I think it was a very, very informative discussion, and keen to look at some of the examples that you've pointed out to us. I think it's useful to us to look at those as well. So we really do appreciate your time. So thank you.
Well, we'll share those with the committee, and it's been an honour to speak to you. Thank you.
Thanks a million. Thank you. Okay, members, thank you. I'm just going to move on to correspondence. If I could refer you to the list at page 299 of your pack. There's just a couple of items I wanted to draw your attention to. At page 356, we've correspondence from the Ulster University requesting a meeting with the committee with the Northern Ireland Obesity Coalition, which is made up of academia from Ulster University, Queen's University Belfast and people with lived experience. And the coalition would like to engage with the committee on the newly proposed regional obesity management service. So just ask members would they be content to get that arranged. I think that would be very, very useful, particularly based on some of the conversations we've had today with the Minister. Yeah. Thank you. We've also received correspondence from Versus Arthritis at page 357, asking to brief the committee on how the current review of the elective care framework provides an opportunity to introduce a commitment to improving the physical and mental well-being of people on long waiting lists. So again, are members content that we get that set up as well? I think that would also be very good. Yes, Nuala?
It was on just overall, you finished then?
Yeah, no, well, if we're happy to agree with that action, then it can go on to anything else.
Yeah, no, it was just from the Association of Social Workers. It's just, I know that some parties have heard from them, and given our priority with children's services, if we could just make sure that they are invited to committee to give evidence as part of the Children's Social Services Review priority, and we haven't heard from them, and we're hearing from the young people soon too, so it should be good.
Yeah, no, I think that's important. Yeah, thank you for that. Are members happy then to note all the actions for the remaining items on the list? Diane?
Just asking two. The one at 7:10, are we simply noting that?
It's just for nothing, yeah. Okay.
And the one at 7:11, the invitation to Daisy Hill.
Yeah, so the chair of the Southern Trust had written 2 weeks ago, I think, just requesting if we would have it. No, we've been doing meetings out and about. If we could have one of our committee meetings.
No, it's just, I actually spoke to Eileen Mullen particularly about this, and which I was, rather than just simply visit the hospital, I was really keen to visit and to explore the acute hospital at home service that they run, which is very, very important.
Yeah.
So it was that aspect, rather than just simply make another visit to a hospital, it was just to dive down into how that works, and whether we can sort of follow the journey even, and maybe speak to some patients who benefited from it. I just think that it's very innovative. And really, yes, really, it's a really good innovation, and I think it would be interesting to do.
Yeah,
so rather, it's described here as a very wide-ranging visit. I really think that would be.
I think what we were keen to do was to develop something like a bit of a programme, so that, like, similar to other areas, maybe have the morning where we're doing those types of things, seeing maybe certain aspects of what they're delivering. And then have our committee meeting in the hospital in the afternoon.
That's fine.
So I think we're thinking maybe potentially January time, but Keith and the staff are going to work on it.
That's fine. I'm really keen to see that, because I think that sometimes we can all talk about all of the things that are going wrong in the health service, but that's a really good delivery and an important innovation.
Absolutely. No, definitely. No, so I think that would be a good suggestion as part of that, Diane. Thank you. Are members content with the rest of the actions for the other correspondence? Yep, thank you. Our forward work programme then, members, the draft forward work programme is in the meeting pack of page 362. Just to remind members that there is an informal session with departmental officials on Tuesday coming, the 22nd of October, on waiting list statistics in room 30 in Parliament Buildings at 1 o'clock. So just if we could, if people could confirm if they're attending or not for that meeting. Are members content to note then the briefings as set out in the remainder of the forward work programme? Thank you. Have members any other items of business that they wish to raise? No. Okay.
Could we ask the Minister? So I've been following this story in the press where Wes Streeting says there's going to be so many hundreds of millions invested in these weight loss injections. So could we ask, how does it, well, it won't apply here unless we do, but will there be Barnett consequentials and funding from that? And will the Minister use that in his obesity strategy?
Okay. Yep, happy to do that. And I think that might help with some of the conversations we're having, because we've talked about the obesity management programme, and that's there with the coalition.
Then maybe just reference
that we're
the issue that was flagged up by the Ulster University group about the start-stop nature of the obesity programme.
No, thank you. Thank you for that. Okay, members, so our next meeting, we're back to Parliament Buildings after a wee hiatus out of the building. So our next meeting's next Thursday, 24th of October at 2 o'clock in our usual room of 29. And just again, I think it's very important to thank the Le Mans Hotel NICON conference, but also our staff here for the committee and our comm staff at the back who've done a fantastic job in getting this live stream for the very first time. And we waited to the end to say that in case there was any blips, but I think they've done a really, really superb job, and it's been brilliant to do it, and hopefully we'll see more of it. So thank you all for putting this together, and thanks to everyone that has come along today. Hope we didn't bore you too much. So safe home, everybody. Thank you.
Thank you.